cancer, probably the word which people are scared most, maybe the word that people are scared most more than death. Cancer is something that relates not only to very often deadly disease, but also to treatment and to painful process of going through different types of treatments, not always giving a hope to survive. But of course, medicine is doing its best to help us to survive most of cancers and is inventing procedures that can help us go through this very frantic experience. My guest today in Extraordinary Stories is Professor Franco Orsi from Milan. Hello. You are a Chief of Division of Interventional Radiology in European Institute of Oncology in Milan. And I think this is a perfect starting point for our discussion, because radiology is pretty well known to many cancer patients over the years. But it is usually related to the very old procedure that is sometimes being used to target cancer cells in a very specific way with radiotherapy. Can you explain where it started and how it is developing right now as a way to help patients in different types of tumors?
Yes, of course. First of all, I would like just to explain better the role of interventional radiology. What you mentioned, the radiation used for treating lesions is usually done by radiotherapists or radiation oncologists. What interventional radiologists used to do is just to target precisely the tumor according to the image guidance, such as ultrasound, CT, or MRI, and using this guidance just for sticking specific weapons into the tumor and destroy it in the same way in terms of outcomes surgeons may do. So in terms of biological point of view, remove the tumor or destroy it thanks to the new energy, such as the heat or the cold, will be more or less the same level. So this is what we do. The reason why radiologists came into the oncology field is because, as you know, imaging made an extraordinary revolution in the field of medicine, mainly in oncology. Now we can see the tumor at the very early stage when the tumor is just birthed. And so we can treat the tumor taking advantage of the very small dimension, avoiding any other more invasive approach. And the reason why radiologists are involved in this task is because we are master in imaging. So we use imaging just for guiding our hands and our weapons.
So as you mentioned, actually there is a hot treatment, we can say, yes, you are burning tumor actually, or there is a cold treatment when you're using cryoablation in order to remove or destroy cancer cells. What is the main difference from the patient perspective between those two procedures?
What we know from a biological point of view is that tumor cells, as any other normal and healthy cells, will die if we increase the temperature over 52 Celsius degree for a few seconds, or if the temperature will go below minus 40. And this is due to different biological phenomena, but however, tumor will not resist. For a patient perspective, the heat has been introduced several years ago. I can tell you probably more than 30 years ago. And it is one of the most ancient energy applied for treating tumors. That's been described even from the Egyptians 4,000 years ago. Meanwhile, freezing the tumor is an almost new concept. And the big differences between the two systems and the two treatment is that heat will induce a coagulative necrosis. That means that all the proteins will be coagulated and the tissue will be destroyed about that. And it is unrelated with kind of tissue we are treating, because the heat will destroy every structures of the tumor. Meanwhile, freeze will only destroy the cells, tumor cells. Meanwhile, the collagen infrastructures, that is the infrastructures that is at the base of any kind of tissue, will be preserved. This is so important because the healing phenomena after the treatment will be much easier, and the treatment will be more gentle than the heat.
What are the tumors that are the most susceptible, to use this word, to this type of treatment? What is treated best by cryoablation?
Yes, according to the mechanism behind the treatment, as you may easily understand, every kind of tumor could be treated. Because every kind of tumor will be destroyed according to this phenomenon. But of course, there will be several organs or tissues that cannot be treated because of the safety reasons. So, for instance, we can easily destroy even a gastric cancer. But the problem is that where the tumor will be destroyed, there will be a sort of a hole in the gastric wall. So the tissue that has to be involved in this kind of treatment are usually the pathological tissue within a solid mass. For instance, kidneys, liver, lung, bones, or soft tissues, such as retroperitoneal tissues.
So, from the perspective of patient, how this procedure looks like? I mean, what's the difference between a surgery when you're just cutting the lesion off and this type of procedure? How it's being introduced into the body? How it's how it works?
There are several advantages among the most important ones. I will underline the fact that any kind of percutaneous approach, such as cryo, doesn't require any scar. And the treatment is very precise because it's based on the imaging guidance. So we need just to stick the needle through the skin onto the target and follow the treatment by using the external imaging.
We are talking about the procedure that looks from the patient perspective as laparoscopy. Yes, it's just introduction of no. Okay.
No, it's no. I mean, laparoscopy is another form of surgery. So laparoscopy means just to go inside the abdomen, for instance, and just take out the tissue, avoiding the scar, the laparotomy. And however, the principle behind the laparoscopy is the same that the principle behind the surgical resection. So the aim is just to take the tumor out. What we do is just to put the needle through the skin into the target, and then freeze the tumor or hit the tumor if we're using the thermo ablation. But we're talking about cryo. So according to the cryo system, we have just to stick the needle into the tumor, crossing the skin, the muscles, and all the tissues in a safety way, avoiding any damage thanks to the imaging guidance. Once the needle is in the right position, we can start to freeze it. And then we can see the ice ball that is, the ice that is forming within the tumor, and it will be even outside the tumor in order just to destroy not only the tumor, but even a safety margin around. This is one of the most important advantage. Then there is another one. We are now in the era of immunology, and we know that immunotherapy is a very powerful weapon against tumor. When we take the tumor out, we are going to avoid, like surgeons used to do. We do not have any immunological reaction because the tumor is taken out. If we freeze the tumor inside the body, the tumor will die, but the proteins of the tumor will be ready just to stimulating the immune system. So we will have even a reaction of the immune system against the tumor or the metastasis far away from the tumor we treated. They will be killed by antibodies. They will be induced to kill them thanks to the cryoablation. This is a field of research, but there is a lot of data that are coming regarding the advantage coming with the cryoablation.
That's very interesting because people might be afraid of leaving actually even the dead cancer cells in the body, yes? Because they might see this as a threat for further development or metastasis of the cancer. So you're saying that's not the case. It's not what's happening in the body.
Not at all. However, once the tumor is ablated, with the heat or with the freeze, is ablated. So it will never come again from the side.
So can you explain why actually this procedure, having read about this different types of tumors that were being approached by the procedure, it started from palliative care, not as a treatment per se, or the treatment that brings up survivorship, so to speak. How it started that way, and why certain oncologists are a little bit hesitant to use this procedure on certain occasions?
Yeah, at the very beginning of our experience as interventional oncologists, we faced only a very advanced stage patient disease. That's because at that stage, it was 30 years ago, the armamentarium we had at the time, and even the imaging guidances we had were not enough just for having very good results. At that time, we only treated patients for palliative purposes, and they were usually patients with no other hope and with no other options. And of course, at that time, our results were not so good because the patients were without any other options, usually with a lot of tumor burden and very complex to manage. Then research by research, we raise up our data and our role in the oncology field is now very well established as one of the fourth column of the oncology key players. One is the oncologists, medical oncologists, surgical oncologists, radiation oncologists, and then interventional oncologists. So by the time we gain a lot of success by not only having palliation for those patients, it means just palliating the pain and all the symptoms, but even destroying the tumor, improving survival.
So to what extent, in your view, this can replace other early options, early treatment options in certain types of tumor? To what extent we can see this as a hope for patients that they would not need to undergo any other procedure because thanks to cryoablation, they might be just treated out of cancer?
That's for sure. It happens with several tumors with the thermoablation. I mean, in the beginning, thermoablation, for instance, was only indicated for a patient not indicated for non-amenable for being resected. But I mean, nowadays there's a lot of guidelines that are pushing medical oncologists, surgical oncologists, just to send the patient to interventional oncologists for doing ablation before any kind of resection. And this is what happened with the thermoablation, and this is something that we now have in our daily practice. For cryoablation is almost the same, different indications, but however, cryoablation is more or less now, and it will be more and more in the future, the first treatment option for instance, the small renal cancer before any resection, or for lung cancer, for instance, or for bone tumors. So, I mean, another evolving field is breast cancer, and we know that breast cancer is one of the most common cancer in women, and the standard of treatment is resection. But we know that for very small lesions, the cryoablation that is not painful can be done without general anesthesia in the ambulatory setup, could have the same outcome of any resection.
You mentioned renal cancer, and I will go to that in a minute. But I also would like to ask you about the differences, how popular the procedure is across Europe. You are coming from the European Institute, you are traveling all around the globe, actually. You've been to Poland. Can you actually comment on the differences in how different specialists in different countries are looking at these procedures right now? Can you say that it's more popular in Italy than, for instance, in Poland, or how this looks like from sort of geographical and mental perspective?
My feeling is that it's completely different than what happened in the past. Now, thanks to the social media, thanks to the website and to the internet and to the very close connection and scientific societies, there are not so many big differences between the different countries, at least in Europe. Of course, there will be small differences according to the different relationship of local diversities. For instance, in my hospital, we are working in a multidisciplinary team. So we discuss every single patient in the multidisciplinary tumor board, and that's a sort of boost for our activities, because we can just show our colleagues how our techniques are really working and which kind of advantages we can give to patients. Of course, there is some resistances, mainly coming from the surgical part. Not always. I can tell you my experience is that even surgeons in my environment are pushing us just to increase activities. But of course, they may be afraid that these new frontiers may replace not all their activities, but some of their activities. And that's true. But however, there will be room enough for everyone, because as I told you before, we have just to think about taking advantage of an early diagnosis just to reduce the invasiveness of our treatment. But there will be, however, even patients with an extended disease, they may only have advantages to be treated with the more traditional and more invasive surgical approach.
Okay, so at the very end of our conversation, I would like to focus more on urology field, because you mentioned renal cancer. How is this procedure really, interesting for urologists? What's promising about it? And are there any other urinary tract tumors or cancers that might be also approached by cryoablation?
Cryoablation is today indicated just for treating PT1A renal cell cancer. It means the tumor that is up to 4 centimeters in diameter. In some situation, it would be even indicated in PT1B, that is the tumor up to 7 centimeters. There are no experiences in treating other cancers, but I know there were some experiences in treating prostate cancer. At the beginning of this experience, the pioneeristic approach failed because of the many side effects, because it was done without any precise imaging guidance. Nowadays, everything is changed. We are more precise and we can follow much better the treatment. The best treatment, the best indication will come out in those environments where urologists may work together in a very close relationship with interventional radiologists, because their experiences together with experience coming from interventional radiologists may enhance the success. So up to now, the first indication for cryo in the urology field is just renal cell cancer.
Okay, so can you elaborate a little bit in percentage points, roughly, how many cancers can be treated, renal cancers, for instance, by the use of this technology? How many patients may count that cryoablation may really save them?
Yeah, I can tell you my experience. In my department, we do around 150 renal cancer patient in a year. That is around 60% of all the renal cancer that are resected, operated or treated in my hospital. And that's because thanks to the early diagnostic workup the patient used to do in the checkup program, we may detect more and more small lesions. And small lesions means better results with the cryoablation and less expense for the hospital, because the patient can be treated in an easy way, and will stay in the hospital one night or at least 2 nights, no more. And this is completely different than what happened in a surgical section. So according to my experience, I can tell you that in a very well-organized hospital, at least 50% of the renal cancer could be treated safely with a very good outcome with the percutaneous cryoablation.
This is really huge number. So what would be your final message for the Polish urologist, for instance, and for Polish patients as far as this procedure is concerned? What they should look for, should they hope for, what they can count on?
Yeah, the message is that this is an image-guided technology. An image-guided treatment means that behind this treatment, one expert in imaging has to be involved. So this is not a treatment that will be done in a surgical setting. This is so important because I can tell you, cryoablation was introduced firstly by urologists more than 20 years ago, but results were not good because they couldn't check actually what happened during the ablation and during the cryoablation, because they cannot see inside the tumor as we can do with our machines. They can only see outside. So the message is for urology is just to set up an organization by involving also interventional radiologists. For patients, we suggest just to go in those hospitals very well organized that are equipped with an interventional radiology department that can help them to receive the updated technology and the cutting edge technology for the treatment of this kind of disease.
Okay, thank you very much. Franco Orsi, European Institute of Oncology, Milan, was the guest of Extraordinary Stories. Thank you very much, Professor.
Thank you. Thank you. Bye-bye.